All right, this is an example of using Chirotouch in the Hether Macro on how easy it is to do a new patient exam. We're simply going to go into the chart notes, and for this person we're going to say that we're going to do an exam, and the type of examination we're going to do is a new patient initial examination. So from there we're going to say that today's date is the 12th, and then this person's coming in with a single complaint. We're going to say next, and we're going to say that their complaint that they're having is neck pain. We're going to go over neck pain, we're going to use the person's full name, and then we're going to simply say that they're having pain in their neck that is rated about a 2, and that they're having this pain with stiffness about 3 days per week. Good. From there, we're going to go over they're not having any pain radiating down their upper extremities. When did this pain begin? It began yesterday, and they don't really know why. So this condition, it began yesterday, and that we really don't have a reason for it, so it's unknown. But we did ask the patient if they've had any falls, trips, slips, or accidents, and they've denied that. From there, we go over aggravating factors. What makes the neck pain worse? And the patient stated that they do not have an increase in neck pain with standing. They do not have any increase in neck pain with walking. They do not have any increase, or they do have increase in neck pain if they sit. So sitting is causing neck pain, and this is noted after about 15 minutes of sitting. From there, we know that bending over doesn't bother it, and we can ask the patient, is there any other activities you do that causes an increase in your neck pain? The patient stated that turning his head to the right and left causes an increase in his neck pain, period. So we can document that fairly easily. We can then ask, is there anything you've done that made it feel better under palliative findings? This person has used Aleve and they have used heat, and that's been all they've used for the last 2 days. We can add any other comments if they want to add it. From there, we go over their past medical history. We can simply say that the person has not had any broken bones. They have had their gallbladder surgery. We can use some iPad shortcuts by creating sentences, so we can type a few letters and it types phrases. We can use, they don't have any traumas. This person is not a female, so they did not give birth to any children. Does not have a pacemaker, and from there we can even say that their general health is they have diabetes. So we have diabetes over here, and we can move on to the next question, which is, again, female, not pregnant. If it was, when is the delivery date or the due date, or whether they're pregnant. From there we move on to the review of systems. We can ask if they wear glasses, and yes, they have prescription lenses. They wear prescriptive glasses. We can ask the patient if they have any problem hearing. They do not have hearing problems. They do have a problem with a decrease in smell, and from there we can say they do have a condition of acid reflux. They do have occasional constipation and occasional diarrhea. From there we can ask if they've had any hernias or whether they've had hernia surgery. They do have a cough. We can add that to there. Does not have any chest pain, no heart palpitations, and again they do have diabetes. From there, we can ask if there's any skin irritations or lesions. We can say no. We can say they do have anxiety and they're on medication for this. And again, we're not going to ask questions regarding mammograms or prostate exams because of the person's age. From there, we can ask about their family's medical history. And the family medical history, they have a history of diabetes and heart disease in their family. And then their personal social is that they seldom drink alcohol. We can go back to that. With the alcohol, we can say that they also used to smoke about 5 years ago, and that they drink 1 cup of coffee a day. From there, we can move over to their employment. What are their jobs? Fireman. Say the patient is a fireman, and move on from there. We can ask who their current medical doctor is. So if we can send a copy of the notes, this person's current primary medical doctor is Dr. Smith. And from there, we can say that they don't have a previous chiropractor. Previous chiropractor has never treated with before with previous chiropractor. So if so, we don't need their name, and we're not going to request the records of this non-existent doctor, but we could put in another doctor's name and request an out-of-town chart notes from a visiting patient. From there, we move over the examination findings under vitals. We can say that the person is 5 foot 5 inches, 5 foot 5 inches, and that they weigh about 180 pounds, and that their blood pressure was 120/80, and that their pulse was 64 their respiratory rate was 16, and that their temperature was 97.5. Good. So, oops, respiratory rate was 16, and their temperature was 97.5. Excellent. From there, we go right under range of motion. We're going to ask, what does your neck look like it's doing? We're going to introduce the range of motion for the neck. We're going to pick the cervical icon, and under cervical, we'll ask the patient to bend their head forward. From there, they have mild restriction going forward. They have mild restriction going backwards. They have mild restriction going to the right, mild restriction going to the left, and they don't really have any problems going from side to side. So rotation is going to be negative, and the patient did have pain with flexion, extension, and lateral flexions. Very good. From there, we go under the reflexes. We can do the reflexes, and we can say that the reflexes were all normal for the upper extremities, and that from there, we go right over orthopedics. We introduce the orthopedics, and we say that the person has one complaint, and then we're assessing the cervical spine. Foramen compression was negative, cervical distraction was negative, but when we did the shoulder depressor, it was positive on the right, and this pain was mild. We can say it was mild and it was located in the middle of the neck. From there, we go right over our pre-adjustment screening. We're going to do a cervical compression test, and with cervical compression, we're going to say that they had a positive cervical syndrome, and the cervical syndrome was located on the right. We can go right into palpation findings. What are we doing? Where are they sore? They are tender at C2, 3, and 4, and they have muscle spasms in the neck and the upper back. From there, we go over radiology. The patient has not had any recent x-rays, and I'm going to send them out for x-rays because we want to see the integrity, we want to look at the alignment, and they have limited range of motion. So there's our rationale. Send them out for 2 to 3 view cervical spine, and from there we go over our assessment. The assessment, we're going to introduce the diagnosis. The person is going to have a diagnosis of subluxation at C2, let's see, 5, 6, and 7. We're then going to say that this is causing segmental dysfunction, neck pain, and that's it. Their patient status is they're a new patient, so we're going to say that they are a new patient under initial therapeutic care. And from there, once they become no longer acute, we can turn the acute back into subacute, and then we can turn their initial therapeutic care. We can get rid of initial and just turn it to there. And then once they no longer have problems, we can move them to wellness and supportive care, saying that their acute condition that they originally came in with is no longer acute, they responded well to care, and they're no longer under active treatment. So we can do that as the patient responds. From there, under status, we would go into prognosis. The prognosis is going to be good. We can add if there's anything slowing down their care. And we can also have the patient fill out a functional outcome assessment. From there, we're going to use the AMA functional outcome assessment. From there, we date today's date that they're doing one form, and out of 150 on the cervical chart, they scored 50, meaning it's affecting a third of their life. We've interpreted that the functional outcome assessment determined that they have a regional functional deficit, and that's when we want our goals to reduce that number or that score. From there, we are done with our diagnosis, our assessment. We're going to go right under the plan. Let's say we want the person to come in twice a week for 1 to 2 weeks and reduce care as needed and give them muscle stim. Bam. We can push one button, type all that, or we can go down the list, how many times per week, what our physical therapy rationale is, when we're going to examine them. But from there, it's already pre-typed. We can go right under our summary for today's visit. We did an exam, we did an adjustment, 1 to 2 regions, muscle stim and heat. We also sent the person out for x-rays. We did an x-ray referral. We also gave the patient some home exercises, and they did one functional outcome assessment. And on their next visit, we are going to give them a copy of this exam so they have it for their records. From there, we're going to go over to physical therapy. Where did we do the physical therapy? We did the muscle stim and heat for 15 minutes to the upper back at T3. We did that to the neck and upper back with the heat. And from there, we also did this in a prone position. We did a manual manipulation. We introduced the adjustments. We say that the introduction for the adjustment was a Gonstead supine. We did C2 on the right, C5 and C6 on the right, C2 on the left. And from there, we can say when do we want them to come back. But first, how did the person respond to care? The person did good. They responded well, and then we're going to use this little dash to make a space. So the next time they come in, we can change the date, how they responded, and then we can actually add the patient stated that after their treatment they had greater increased range of motion and the pain was instantly gone, period. So we can add information regarding how they did that treatment after they got adjusted. From there, we go under return visits. Our return visit is going to be simple. We want the person to come back once more at the end of this week, and that our goals are going to be to increase range of motion, decrease pain. We want to reduce their functional deficits, and on the next visit, we're going to ask them to give us their ADLs, their activities of daily living. I can go over that in a second too. We're missing any work, so we don't have to give them a return to work status. And again, the functional outcome assessment, which was scored a 50, we would like to see go down at least 10% by their next examination. And again, this 10% could be, we want to go down by 15 or 20%, and we can be so more precise that not by their next evaluation, but we want to have that decrease within the next 10 treatments. Excellent. So from there, we can go over some specific goals. Let's look back at their pain chart and let's see how they scored as far as their pain goes in the neck. We can say that their neck pain was a 2, and so for our specific goals, we would like to see under goals specifically, we would like to have that pain down from a 2 down to a 1 within the next 2 weeks. So we can say their neck pain is a 2, and we want to see it reduced to a 1 in the next 2 weeks of care. Awesome. We're going to introduce some home exercises. We're going to say that we're going to give the exercises to the neck. We're going to give them neck exercises for muscle spasms, which are right here. Scaling, stretches, rotation, chin tuck. Again, all works cited and documented, and we can go from there. Basically, at this point, we're done with the examination. On the next visit, if we wanted to go over some activities related, some functional outcome assessments or ADLs, we can say ADLs that are limited due to pain. So because today's date, we're going to do it instead of the last visit, we can say that their neck pain is interfering with them sitting comfortably for 30 minutes, and they are having difficulty with, well, let's say, sleeping for 4 hours. So we can also go back to our goals, and for our specific goals, we can say that we would like to see them with their activities of daily living sleep better with their chiropractic, muscle stem therapy, and home exercises. We would like to see them be able to sit for 30 minutes without having pain comfortably, and we would like to see them sleep for more than 4 hours in the night. And again, we're going to do that within the next 2 visits. And then we simply create an alert on the iPad in 2 weeks to go over to see if these goals have been met. We could follow up with it and say what date they originally set, what's today's date, and where they are now, and then update whether our goals were met or if they weren't met. If they were met, we're going to continue care and we're going to update the goals. And if they weren't met, we're going to either change therapy, continue the treatment plan, or recommend additional testing, MRIs, or even referral. And then you simply save it, and we are done with the examination. Thank you very much for watching. If you have any questions, please feel free to give me an email. That's jameshether, Hether, @gmail.com. Thanks, and have a blessed day.